Good morning, Ronnie. Welcome. This is Dr. Call.
Good,
Can you hear us?
good morning, sir. Yes, sir, I can hear you well. And welcome to Kochi.
Great.
And at the outset, let me introduce my colleagues, Dr. Jabir, Dr. Joe, Betty, Shilpa, and Wilson. We're going to show an interesting case today. And let me ask Jabir to start with the case.
This gentleman is a 65-year-old, 4-year-old person. He has been diabetic for long, 15 years. He started experiencing hyperangina almost 3 months ago and accelerated angina for last 2 weeks. Electrocardiogram, no significant abnormalities. Echocardiogram, good LV systolic function, no regional wall motion abnormalities and normal valves. And a treadmill test was strongly positive for inducible ischemia. And now we'll show you the angiography. Coronary angiography, you can see the left main is normal. The LAD is a pretty large LAD, type 3, proximal LAD, a long segment disease, densely calcified with eccentric calcium. And the calcium is extending even up to the mid part of the LAD. The circumflex is having an 80% stenosis, and RCA is also diseased, calcified.
Right. So, sir, now this is a shoot I have done just now.
Yeah, we can see it.
If
very
you look
well.
at the proximal LAD, there's significant calcium over there.
Did
Let's
you
go to the
say
next
that the
shoot.
patient is a diabetic?
And
Yes,
Okay.
a long-term diabetic, 15 years.
Right.
and that's the PA caudal. Again, it shows more or less an eccentric calcium over there. So what I thought is I wanted to evaluate this calcium, and we decided that let's do an OCT to see what is the thickness of the calcium, the length of the calcium, so that we could decide on a calcium modification therapy. Go to the next. So I tried to put an OCT catheter, and as you would see that the OCT catheter wouldn't go through that, tight point of that calcium. And I tried again a tube balloon, and when a tube balloon wouldn't go. So at this point, I decided that I got to rota that to cross that. And hence I changed this to the rota C wire, and we did some rota runs so that we could at least put the OCT catheter in. So that's the rota. I think it required 6 or 7 runs and pecking for us to cut that calcium at that particular point of time. And of course, finally, I think next one, I think it gave way. And
This is a
right.
1.5 block?
Next, now once precisely, sir.
Yeah.
So once we did this, go to the next. The tight point seemed cut, and next we were able to take our OCT catheter. Next, we were able to take our OCT catheter inside, and this time pretty easily. Now, once we got the OCT catheter inside, now I want to run the OCT and show you what we exactly saw in this OCT. It's a pretty interesting OCT. Can you have the OCT on the main screen, please? OCT on the main screen. Right. So, if you look at this run, as you come distally, it's co-registered. So, stop there. At that particular point, if you see, there is a nice calcific speck over there. And if you look at can you just tell me the diameter of that calcium? And it's roughly, if you take it from there to there, it's around about 0.8 millimeters or 0.9 millimeters. So now come proximally again. And that's exactly, if you see, at that bend in the LAD. Now, immediately after, proximal to the diagonal, you see another huge calcific chunk over there. And what's the diameter of that? About 1 millimeter. And a little more proximally, if you come again, very eccentric calcium, the whole thing is there, stop there. It's more or less a 360-degree arc of calcium. And if you see, the rota has cut exactly inside about 1.5 millimeters. And I think this is one of the points that I wanted to tell everybody, that when we think of calcium modification, we always think of a rotablation versus a intravascular lithotripsy. And we think that, they compete against each other. No, they don't compete. They are actually complementary.
Yeah.
Like for example, like a calcium like this, at that point that you see on the OCT, we have punched a hole of 1.5 millimeter with a rotablation. This will now permit me to take an IVL catheter inside and then disrupt the calcium in the media, which is about 1 millimeter, so that my stent gets expanded. And I think this is an important point that needs to be elucidated, that, IVL is going to cut the mid-calcium and help your stent to expand to 3 millimeters. What's the calcium score meanwhile at this point? Jabir, can you just tell us that?
As many of you know,
Let me take the,
there is something called a calcium
the
score by the OCT
IVL
where they
balloon.
look at the length of the calcium, the arc of the calcium, and the depth of the calcium. The arc has got 2 points. If it is more than 180 degrees, and you can show it, it is almost 220 degrees calcium arc here, with a length of course, more than 5 millimeter, and the depth even beyond 1 millimeter, beyond 1 millimeter. So when we add together, it is 4, which is the maximum score in the calcium score, which tells us that there is a high likelihood of stent under expansion, and that is the utility of this calcium score.
Now, can we get back onto the camera, please? So
Dr. Gurpreet,
our
would you have
aim right
suggested
now is
something else?
as
I'm just
I
asking my co-chair, Dr. Gurpreet, about his, comments, and would he have done something different?
Yeah, so I think this is a very sensible approach, heavily calcified vessel, doing a rotablation, and then doing some sort of intravascular imaging to assess this further makes sense. My only one question would be, the distal left main, that looked a little bit tight. It was barely the size of your rotablator burr. Does that need to be assessed further?
You can have a look at the OCT there in the left main. You show the left main
yeah,
OCT.
we did assess that, and the diameter of
can see
the
the
left main is quite big over there, and it's definitely more than about 6 millimeters square. So we really did not bother about that.
And no significant lesion
So
in
can
the
we
left
go
main.
on to the camera, please, so that I can show you about this IVL there, IVL here. So now, this is the IVL catheter that I'm going to show you. Can you put that on the main screen, please? Right. So, hold this. Can we have the camera on the big one? So this is the connector of the IVL, and I think you can see the IVL screen also. Right, so this gets connected into this hub, which is a magnetic connection, and it gets connected pretty easily. And once it gets connected on the IVL, we're not getting this on the main screen. Are you coming? Yeah. So you see, it gets connected to green, so it shows that the IVL is active.
Anybody in the panel would have
This
done something
balloon
different?
actually is just,
Would you have upsized the burr, or would you have preferred to do lithotripsy, shockwave therapy?
now this IVL balloon is about 12 millimeters long, and if you notice, there are 2 emitters in this, and these 2 emitters are around 6 millimeters away. It's a pretty bulky balloon. It's a 042, and that comes to roughly around a millimeter. And we sized this balloon as 3 millimeters based on the OCT, because in the OCT, they showed us that the EL to EL diameter was roughly around 3 millimeters. Can you hold this wire? Now, this is a bulky balloon, and that is why we had to do the rota to get this balloon inside. This balloon is not going to go where OCT catheter or a 2 millimeter balloon doesn't enter. So I'm going to try and see that after OCT whether this actually goes inside.
Ronnie, how long have you been doing this
Yeah, see, it's showing.
shockwave therapy? Have you been doing?
I've done about 5 cases so far, sir, and right, I think we are in the right point. So once we have reached this point, what we normally do is, if we can show the IVL machine also on the side. Right. So now if you see, there are 80 shocks on that, and each cycle has got 10 pulses. So first thing what you do is you inflate the balloon to nominal, and that's 4. Go there to 4. And once you go there to 4, I press the button on this, and now it's going to give cycles. You see that? 79,
Yeah,
78, 77, 76. And did you see that waist of the balloon going off? So,
Yeah, that's right.
so when 10 pulses are over, now you go to another 6 and go negative.
That looks really nice.
So we know the calcium over there got disrupted. Now you come a little more proximal. Keep negative, keep negative. We're finding it.
Okay.
Right. Out
Shall I
there, we again go to 4.
I'm at 4.
Now you see the great waist over there. Let us see if the waist goes. I'm going to again give the next pulses. I started the pulse, and the moment you start the pulse, you see that the waist goes.
That's right.
So that's this. I think I'm going to give 10 pulses again over here. Now it has reached 60. Show the IVL machine, please.
Yeah, show the machine. Yes.
Shall I go to 6 and come down?
Come on, guys. 6 negative.
Yes.
Now I'm going to carefully come again a little more proximally there. And
I'm
go
going.
to 4.
Yes, I'm at 4.
You see I'm starting the pulse again. So you see now it counts down from 58, 57, 56, 55, 54, 53.
Yes, 50.
And now we have now finished the cycles down. Now let me see how this looks after we have broken the calcium. It looks good. It looks good. I think we don't need to do any further pulses. I think over here I want to give another set here.
Okay, I'm going up.
Go to
There is
4.
a question from one of our
Yes.
delegates here.
4.
Can this calcium be managed by
Good.
OP
So
and
I'm going to
NC
give another
balloon?
pulse.
OP and NC balloon, as you know, is a very high pressure balloon. You can go up to 40 atmospheres.
I think we're given there, but then still there is a little eccentric part of the balloon that's still not gone up. So I'm going to give another 10 over here. So
I
again,
think,
I'm going to give another 10.
It needs something more than a
4,
balloon.
4, 4, 4, 4.
It's okay.
4.
4.
Right. Okay. I'm going to give here another 10 pulses over
Somehow
here.
need to crack
at
this
4.
calcium.
Yeah. No,
And
Yes.
I think the calcium is cracked there. Negative.
Because that balloon may inflate eccentrically and not really do anything to the calcium. So your ultimate result of deploying the stent is not going to be perfect. And if that is not perfect, then
Good.
the short-term and intermediate results are not good.
Yes, because, I think that is a good point that was said. But, I'm going to put an OCT over here and show you what has happened now once the calcium has been disrupted. Can you take the OCT catheter inside while I show them this balloon here? Now, I want you to show this balloon here. It's a pretty interesting thing that I found out. Can you give me this here? And if you can show me...
Can I have the OCT catheter?
or here from there. If you look at this, this is the catheter. You inflate this to 4. You go on.
OCT.
And when you are actually shocking this if you can see,
Leave it.
take that out, yeah.
Okay. Ah, right.
Right. So here, you see, this is how it goes, and you don't feel a thing because it shows the light over there,
Just flush here.
Yes.
but then you don't feel a thing, but it cracks the calcium.
So the key is not to expand it at very high pressures.
Right.
You just make it open and then deliver the, shock waves. Not to go to 12, 14,
Absolutely.
15 atmospheres, because that's not the job.
Okay, and let's go back to OCT now. Hold this.
And I think for the audience question about whether we should use a high pressure balloon.
Hello,
case,
Ronnie. Hi, this is
in the
Bhavesh here.
majority of cases that will work quite
Tell
well.
me if
Yeah.
there is a lot
Hi,
of
Bhavesh,
calcium
how are you?
and you need to do more pulses than 80, then what happens? Do you change the balloon? How does the cost imply?
Good question. I think we should tell the manufacturers this because they allow us only 8 pulses. 8 cycles of 10 pulse each. If you're going to go more than this, we've got to change the catheter. And that's, I think, the technology is very exciting because very simple to use, but I think cost is something that we need to manage.
Okay.
So I'm getting ready for the OCT run. Can you have OCT on the main screen, please?
I'm operating from here. Yes?
Right. We calibrate the catheter, and I'm doing the run right now. Inject. Good. Now let's analyze the OCT and see what has happened.
Okay.
Right, now let's get on to the
2.5
OCT.
balloon. 2.5 balloon.
We are just co-registering it so that we get a better information at that point of time. Okay, if there's getting time co-registering it, okay, right, we are co-registered it, right. Now move to all those areas of calcium which we had initially detected, and let us see what has happened to that point.
2.5 balloon.
Now do you see this disruption over there of that calcific nodule over there, which we had initially found at that point?
2.5.
Yeah, very well.
Now come more proximally. Come more proximally. More proximally. Now let's come to a little more proximally where we see the eccentric calcium. More proximally. More proximal. More proximal. There. That's another area where you see disruption there. Come more proximally. Little more proximal. Okay, you see the cut right there at 3 o'clock position, that calcium that's disrupted there at 3 o'clock. Come more proximally. More proximal. More proximal. More proximal. Now, there. So, I think, sir, we have been lucky this time that, can come to the camera,
4, 6, 8, 10, 12.
that we have been able to see these disruptions of calcium. But what I have noticed in this last cases that I did is that you really sometimes may not be able to see this disruption in calcium. But it causes these microfractures, and these microfractures, make the calcium so compliant that your stent can go up. I want the
Ronnie,
camera.
you have 6 minutes before we move to the
Right.
center.
And another advantage
Spin
I found of this
2.7538.
IVL was that when you say that these are sonic pressure waves that go to the side of the wall, we must realize that this creates a 50 atmospheres pressure on the wall.
There is a question
And
that
this
what is
50
the
atmosphere
rate
pressure
of
on the wall is something that's very good.
rate of slow flow with the lithotripsy versus rotablation?
And 3 mm balloon.
Right, so that's a good question, and I have not had any slow flow in the cases that I have done until now, and even the Disrupt 2, the CAT Disrupt 2 trial that showed, that's the greatest advantage of IVL. There is no slow flow, there is no dissection, there is no perforation.
Yeah, I think it makes sense also because rotablator pulverizes the calcium and throws it forwards and for the reticuloendothelial system to take over. Here there is no, distal embolism, which you're changing the substrate, you're, cracking the calcium, leaving it there. Yeah.
It's just fracture, it's not going
You're just fracturing it.
So now, based on our OCT, we had decided for a 38 millimeter stent. So I want you to see the 38 millimeter stent and see if you are able to open it up well.
Proximal.
Because if we have actually disrupted the calcium, you must see a smooth expansion of this. Yeah, that's fine.
Yeah, that's.
Come to the cranial view.
I'll pull a little bit behind.
Can we have the angio on the screen, please?
Cranial view. Right.
Yes,
Please put the angio on the screen before you start inflating it. Let's get the angio on the screen before. Right. Okay, go up.
Go.
Now let us see if this has a uniform expansion. You see?
8.
It's at 8
10.
atmospheres. It has expanded so beautifully, and I think that's because of the pulverization of calcium.
Down.
A few more questions. Any perforation seen by this technique? And what are the sizes of the balloons available?
Again, I think I have not seen perforation,
Three
and even the Disrupt 3 trial did not show any perforations in their data.
And the final OCT.
The balloon sizing comes in 2.5, 3, and 3.5.
Yeah. Well, angiographical, an excellent result.
And all of them are 12 millimeter long. Be careful about that ectasia point.
Be ready with
And
the OCT.
I think one of the good thing about this technology is that, it is very simple to use. So I think it can be used, but you don't need to have that, learning curve of rotablation.
Yeah.
But what I was concerned was the fact that a lot of people said it's going to replace rota. It's not going to replace
No, it's
rota.
a complementary thing.
Go.
Yeah. What about orbital atherectomy?
Absolutely, sir, absolutely.
Orbital atherectomy?
Go. 12, 14, 16. Down.
I really have no idea about
Yeah.
that, sir, because I've not been able to get my hands on an
Yes.
orbital atherectomy, so I really do not know how well that would work with this. But
down.
I think maybe, I think disrupting calcium, this is a very good tool. Cost is a factor that I think needs to be addressed, and some of the cost needs to come down over a period of time.
Great case. And Ronnie, I wish you had recruited it in the Tuxedo 2 study. Ideal case, triple vessel disease, diabetic. Only the choice of stent would be,
Let me,
randomized.
yeah. Let me just show you a final angio picture before we go offline. Just give me 2 minutes more.
Go.
Negative.
Yeah.
Negative.
Take it
You
out
have
and just
2
give
minutes,
a
yes.
shoot over there. Jabir?
Yeah.
Yes.
2 minutes, can we run a OCT?
No. First, just give a shoot, and then I assure you the OCT will show a well expanded, well opposed stent there because the calcium has been removed.
Well, there's a question whether you
Right,
need
let's
to
do the last
prepare a
shot.
vessel
I
bed,
think-
which you already done, because you have to make the catheter
Yes.
go across the lesion. Unless it goes
Right,
across the
so-
lesion, you can't do
Yeah,
it.
look at this. I think it's a. I think you'd agree for a calcific lesion like that. It's a fantastic result.
Yes, absolutely.
It looks very nice.
Yeah.
So, if you will give us time, we'll run an OCT. Otherwise, on behalf
take
of all
only
of us
one-
at Lisie Hospital, I think
Hold
I
it,
will thank you all. And on behalf of Dr. Jabir, Joe, Sister Betty, Shilpa, come over here. Wilson,
Yeah. Great show.
Anu,
very good,
and our
very
OCT man,
interesting
Santosh.
case.
Santosh, come over.
Complex case, done so well,
Right,
and showing a new technology.
right.
That's what India Live is meant for. Thank you so much, Ronnie.
Right, and On behalf of all of us, thank you, sir.
Great, and see you in Delhi. So now we move to
Yes, sir.